Hello guys, welcome to our channel PLAB.RECAPS. Today we'll be discussing a topic under cardiology, which is hypertension. Any topic which has an asterisk placed next to it is just to provide emphasis that this is a topic that you owe to focus on for your clinical exam as well. What part of the topic you need to know for your clinical exam is something we will discuss with you later. Please know that we will not be discussing hypertensive emergencies or management of hypertension in pregnant women or those who are trying to get pregnant, breastfeeding women, or a management of hypertension in chronic kidney disease. These are topics that will be discussed in their respective specialty folders. So let's begin. There are many types of antihypertensive medications that are currently being used for the management of hypertension. I will be discussing the various types and their mechanism of action. Do pay attention as this is sometimes asked in the exam. I have listed the maximum dose of some common medications that are mentioned in the exam. However, you do not need to memorize these doses as PLAB doesn't require you to do so. Sometimes in the exam, one of the options in the MCQs may be stating to increase a dose of a single medication, a single antihypertensive medication. However, the general principle is that before increasing the dose of a single medication, you first try combination therapy on lower doses. So the reason I am listing the maximum dose is just to make you familiarize with how high up you can go with these medications, so that it doesn't come to you as a surprise in the exam. I will be mentioning some common side effects of medications. However, if you are interested in knowing more rare side effects, I will leave a link down below for you guys to type in the medication and read in detail about it. But yeah, I'll be sticking to just the common ones that are asked in the exam. So ACE inhibitors and ARBs are common antihypertensive medications that are used for the control of hypertension. These interfere with the renin-angiotensin-aldosterone system. So basically, there are certain factors that help stimulate renin secretion. This includes a decreased blood pressure or a decreased sodium delivery to the macula densa of the kidney, or an increased sympathetic tone. When this happens, the kidney secretes a renin. Renin helps convert angiotensinogen, which is produced by the liver, to angiotensin 1. Angiotensin 1 is then converted to angiotensin 2 with the help of the angiotensin converting enzyme, which is released by the lungs and the kidneys. Angiotensin 2 then attaches to AT1 and AT2 receptors, which are present in various organs of the body, to produce an effect that helps increase the blood pressure. Now, ACE inhibitors block the action of the angiotensin converting enzyme. Thereby, angiotensin 1 is not converted to angiotensin 2. Therefore, the pathway is blocked, and this helps reduce blood pressure. ARBs, on the other hand, block the AT1 receptor. Therefore, angiotensin 2 is unable to attach to those receptors. These receptors are present in the heart, blood vessels, kidneys, adrenal cortex, and the lungs. When angiotensin 2 is unable to bind to these receptors, so therefore the pathway is again blocked, and angiotensin 2 is not able to carry out its action on these organs, thereby again helping reduce blood pressure. The common side effects of ACE inhibitors include a dry cough, hyperkalemia, fatigue, dizziness, headaches, loss of taste, and angioedema, especially in Black people, women, and smokers. A common question is regarding a patient who might be on ACE inhibitor and developed a dry cough, which is persisting and troublesome for the patient. So, what do you do in such a case? Generally, the answer to it is just to switch them over to an ARB. Side effects of ARB include dizziness, hyperkalemia, and angioedema. Beta blockers are generally not the first line agent for the treatment of hypertension. They are not used for uncomplicated hypertension. They're mainly used when combination therapy with many other medications is not working. Then you go for either a beta or an alpha blocker. Now, beta blockers are beta adrenergic blocking agents. These help reduce your blood pressure by blocking the effects of the hormone epinephrine. Beta blockers can cause your heart to beat more slowly and with less force, which helps lower blood pressure. They also open up your veins and arteries to improve blood flow. Some beta blockers mainly affect your heart, while others affect both your heart and blood vessels. This depends on where the beta blockers are acting. So beta receptors are present throughout the body. Beta 1 receptors are in the heart and kidneys, while beta 1 receptors are mainly in the heart and kidneys. Examples of these are atenolol, bisoprolol, and metoprolol. So their effects are predominantly on the heart. While beta 2 receptors are on the lung, bronchioles, smooth muscle, vasculature, the GI, and beta 3 in fat cells. So depending on where the beta blockers are acting, you can see its action accordingly. Side effects are based also upon where the beta blockers are predominantly acting. So for example, if it's a heart, then it may produce bradycardia, worsen heart failure, bradyarrhythmias. If it is the lungs, then it may cause bronchoconstriction. Therefore, it is a common question regarding worsening of asthma with a patient on who has been started on beta blockers. Smooth muscles, it can cause vasoconstriction, therefore it needs to be avoided in peripheral arterial disease. It can also cause erectile dysfunction and Raynaud's phenomena. Beta blockers can produce hyperglycemia, and this occurs by beta blockers blocking the action of the pancreatic beta cells. Therefore, insulin is not produced, and this leads to hyperglycemia. However, beta blockers can produce the opposite action as well, which is of hypoglycemia. So generally the liver produces glucose by the process of glycogenolysis. However, beta blockers block this process, and therefore it can cause hypoglycemia. Other side effects include hypertriglyceridemia and orthostatic hypotension. Calcium channel blockers help lower your blood pressure by preventing calcium from entering the cells of your heart and arteries. Calcium causes the heart and arteries to contract more strongly. By blocking calcium channel blockers allow blood vessels to relax and open. Some calcium channel blockers have the added benefit of slowing your heart rate, which can further lower your blood pressure, relieve chest pain, and control an irregular heartbeat. Now, there are two types of calcium channel blockers. The dihydropyridine calcium channel blockers, such as amlodipine, felodipine, nimodipine, and nifedipine, they predominantly act on the vascular smooth muscles rather than the heart, and therefore help reduce the blood pressure. Common side effects of calcium channel blockers include swelling in the feet and lower legs, flushing, constipation, Others include palpitations, headache, nausea, rash, and fatigue. The next class of drugs are thiazide like diuretics. These are moderately potent diuretics that help lower blood pressure when given in lower doses. They inhibit the sodium reabsorption at the beginning of the distal convoluted tubule in the kidneys, therefore increasing water loss or causing diuresis. The side effects of thiazides need to be known because they are commonly asked in the exam. Uh, the mnemonic that needs to be remembered is hypergluc plus 3 hypos. G stands for glucose, L stands for lithium, U stands for uric acid, and C stands for calcium. So it basically causes hyperglycemia, high lithium when given in combination with mood stabilizers such as lithium, hyperuricemia, therefore it is contraindicated in gout, and causes hypercalcemia. The 3 hypos is everything else, so that's hypokalemia, hyponatremia, and hypomagnesemia. In addition to this, thiazide-like diuretics can cause postural hypotension, erectile dysfunction, and skin sensitivity to light, which get resolved on stopping the medication. Also causes dizziness and dry mouth. Alpha blockers are used in combination with other drugs to treat high blood pressure. They lower the blood pressure by keeping the hormone norepinephrine from tightening the muscles in the walls of small arteries and veins. As a result, the vessels remain open and relaxed, and this helps improve blood flow and lower blood pressure. Common side effects include first dose effect, which is a pronounced drop in BP, causing dizziness and fainting. Others include palpitation and weakness. There are also a new class of medication called the direct renin inhibitors, such as aliskiren. These inhibit renin, therefore, a conversion of angiotensinogen to angiotensin 1 is prevented, thereby the pathway is blocked and blood pressure is lowered. These are generally used when a patient cannot tolerate any other all the other types of antihypertensives that are available. There haven't been very many studies done around this medication, so I have just mentioned for the sake of completion of this topic. This is the most important slide in the entire presentation. Majority of the questions are designed around the management of hypertension with antihypertensive medications. It is worth mentioning that adherence and lifestyle needs to be assessed at every step in the management. So every time you move up a step, make sure you ask the patient regarding adherence, because if the patient is not being able to tolerate the medication because of its side effects and so on, then they are probably not taking the medication, which makes achieving blood pressure control more difficult. Also, try to investigate how much of a lifestyle modification have they been able to make, if they are finding anything difficult, and if there is help or any advice that you can give. So now let's begin with the management itself. The simplest way of knowing on what step the patient is of treatment is as simple as, if they're on step 1, they're on one antihypertensive medication. If they are taking 2, then they are on step 2. If they're taking 3 antihypertensives, then they are on step 3. And if they are taking 4, then they are on step 4 of the management. Now, management itself depends on 3 things. 1 is age, 2 is if they're diabetic or not, and 3 is on their ethnicity, specifically Afro-Caribbean race. So if they're less than 55 years of age, or they have diabetes, and they're at any age or of any race, then it is advised to start them on ACE inhibitors or ARBs. Please note that if the patient is of an Afro-Caribbean race and has diabetes, then it is preferred that they be started on an ARB rather than an ACE inhibitor. If the patient is more than 55 years of age, does not have diabetes, or if they are from an Afro-Caribbean race and do not have diabetes, no matter what age they are, it is advised to start them on a calcium channel blocker. If the patient is not being able to tolerate calcium channel blockers because of side effects like edema and so on, then it is advised to start them on a thiazide-like diuretic. Before moving to step 2 of the management, make sure you check with the patient regarding adherence and provide any lifestyle advice where necessary. So if the patient has been on step 1 treatment with an ACE inhibitor or an ARB, then it is suggested that you add either a calcium channel blocker or a thiazide-like diuretic. If the patient is on step 1 management, however, is on a calcium channel blocker, then it is advised to give them either an ACE inhibitor or an ARB in combination with the calcium channel blocker, or add a thiazide-like diuretic. Previously, it was not advisable to give a combination of calcium channel blocker with a thiazide diuretic. It was advised to first add an ACE and an ARB before moving ahead with adding a diuretic. However, this has changed in the 2019 guidelines, and you can give a calcium channel blocker in combination with a thiazide-like diuretic. Please note again that if the patient is from Afro-Caribbean race and you are planning to add on an ACE or an ARB, it is advised to start with an ARB instead of an ACE inhibitor. Before moving up a step, it is advised to check on adherence and provide any lifestyle advice where necessary. So if the patient is not being controlled on 2 antihypertensive, then it's advised to add a third antihypertensive medication. So it is advised to give a combination of an ACE or an ARB with a calcium channel blocker and a thiazide-like diuretic. Previously, when it came to thiazides, previously medications like thiazide or chlorothiazide were being given. However, now it is recommended to start off with medications like indapamide. However, if the patient has already been on thiazide or the traditional drugs and they are tolerating it well, and you have been able to have a good blood pressure control, then there is no need to switch to indapamide. Before moving up a step, it is recommended to assess adherence and give lifestyle advice wherever necessary. If the patient if the patient has not got good control of blood pressure despite being on 3 antihypertensive medications, then it is recommended that you move up a step. Before moving up a step, you can either get advice from a specialist regarding which antihypertensive medication to add, or you can add one of the 3 classes of medications, so either spironolactone or a beta blocker or alpha blocker. So before adding any of these medications, it is necessary that you do blood tests for assessment of renal function and sodium and potassium. Before adding spironolactone, you need to be really careful regarding the renal function and potassium levels in the body. If the potassium level is less than or equal to 4.5, then you can add low-dose spironolactone. If the potassium is more than 4.5, then add an alpha or a beta blocker. Please know that after adding a fourth antihypertensive, it is recommended by NICE guidelines that the renal function and sodium potassium are repeated after 1 month, just to make sure that everything is okay. If the patient is on 3 antihypertensive medications and their blood pressure is not controlled, then they have what is called a resistant hypertension. If the patient is on 4 antihypertensive medication and their blood pressure is still not controlled, then they need a specialist review. Target blood pressures can also sometimes be tested in exams. So if your patient is hypertensive but under the age of 80 years, then the target blood pressure is less than 140 by 90. If they are hypertensive but more than 80 years of age, then the target blood pressure is 150 by 90 or less. For diabetics, previously patients with diabetes traditionally had their BP controlled more aggressively to reduce the overall cardiovascular risk. However, in 2013, there was a Cochrane review that was conducted, and between two groups that were diabetic. So one group was made to have a more tighter control with a target blood pressure of 130 by 85 or less, while the other group had a more relaxed control of blood pressure targets 140 to 160 systolic or and 90 to 100 diastolic. The results showed that the group which had a more tighter control had only slightly reduced rate of stroke, but otherwise overall outcomes were not significantly different between the two groups. Therefore, NICE guidelines now suggest that for type 2 diabetics, there's a bit of more relaxed control. So the target blood pressure is between 140 by 90 or less. For type 1 diabetics, the target blood pressure is 135 by 85, except that if they have albuminuria or 2 or more features of metabolic syndrome, then a more tighter control of 130 by 80 is required. We need to be aware of situations whereby we need to make a specialist referral or a specialist referral for same-day review. We need to make a specialist referral if the patient has severe hypertension but has no signs or symptoms indicating a same-day referral. If the patient has hypertension and is less than 40 years old, he or she needs further investigations for secondary causes of hypertension. If the patient has resistant hypertension, then you can consider calling a specialist just to get some advice on management of hypertension, that is adding a fourth drug. If the blood pressure is not controlled despite being on 4 antihypertensive medications, then this indicates a specialist review. The patient needs to be urgently seen for same-day specialist review if the patient has a clinic blood pressure of more than 180 systolic or 120 diastolic, and also has signs of retinal hemorrhage or papilledema or any life-threatening symptoms suggesting malignant hypertension or accelerated hypertension. As we've discussed previously, any signs of chest pain, headache, nausea, vomiting, blurring of vision, swelling in the legs, or any signs of acute kidney injury, it would require a same-day specialist review. Thank you. As we near the end of our topic summary, I would like to give you some exam tips. Keep these in mind as they may help provide clarity as you attempt to answer MCQs. First and foremost is about lifestyle advice. Lifestyle advice is mandatory, so don't take it lightly. It can be the answer to one of the questions. Offer people with isolated systolic blood pressures of more than 160 the same treatment as people with raised systolic and diastolic blood pressures. The two situations with where ARBs are almost always used is if the patient is not tolerating ACE inhibitors, so you switch to an ARB. And the second is if you need to start a treatment with ACE inhibitors in a patient with Afro-Caribbean descent, always choose ARBs over ACE inhibitors. So for example, in a diabetic patient of any age or race, the recommendation is to start ACE inhibitors. However, if the patient is of Afro-Caribbean descent, then instead of giving an ACE inhibitor, give an ARB. If a patient is diabetic, the age doesn't matter, just offer ACE inhibitors. If the patient is from an Afro-Caribbean descent, again, age doesn't matter, just offer a calcium channel blocker. If the patient is diabetic and from an Afro-Caribbean race, again, age doesn't matter, offer an ARB over an ACE inhibitor. If the patient does not tolerate calcium channel blockers, or if the patient has chronic heart failure, attempt to give a thiazide like diuretics such as indapamide. So these are some more exam tips which may not be as significant as the previous slide. However, they may be things which are mentioned either in the hidden in the question or the answer, or something they're hinting towards. So I thought I'll just mention these. Offer antihypertensive drug treatment to women of childbearing potential with hypertension, the same as the stepwise management that we have discussed in this presentation. Women who are hypertensive and are planning to get pregnant, or those who are pregnant and have hypertension, this will be discussed separately in the obs and gynae folder. So the management for them is different. Do not combine an ACE inhibitor with an ARB to treat hypertension. This is something I have mentioned before. When moving a step up, always check adherence and lifestyle. If a patient is on step 3 and the BP is not controlled, consider them as having resistant hypertension. So confirm their ambulatory and home blood pressure monitoring again before moving on to step 4. Assess postural hypotension and discuss adherence with the patient. If the EGFR is reduced or if the potassium levels in the body are high, be careful in prescribing spironolactone. Step 4 treatment, monitor blood sodium and potassium along with renal function tests within 1 month of starting the treatment. Thank you guys for your attention. We hope that this topic presentation was helpful. If you did find it beneficial, kindly leave your comments below and also leave us some suggestions on how we can improve. See you soon in our next presentation. Thank you once again, and together we can do this.